So like we started off with on the last one where we had the pectoral girdle and like proximal distal doesn't matter for them, doesn't in this either. So we're looking now at the pelvic girdle or the pelvis. This isn't really a pelvis because it's just one part of it, but this is a hip bone or the innominate bone or os coxa. I always liked os coxa. It felt like it was a spell. So the hip bones, they're going to be paired structures. They're actually not a single bone. This is going to be 3 fused bones that during development fuse so tightly that we can't actually see the sutures that we can with the skull. If you look at the hip, the lateral aspect, so this hip would sit about like this in the body, if you were looking down, or if you were looking towards the front of it, then this would be inferior and superior. On the lateral aspect of it, you can see where the femur sockets in. And so it fits in to that acetabulum. And so this gets its name from like vinegar cup, like acetic acid, acetabulum. This is actually 3 different bones that form fuse to make this structure. So if we were to kind of make a upside down peace symbol, so now I've got the hip, like the inferior portion is facing towards me, anterior is to the left on the screen, posterior is to the right, superior is that direction. So if we take a line and we go down and then we divide it as an upside down peace sign, so like we're looking at this and we do that to the acetabulum, then you can, or if that's your peace sign, I guess we got to make it upside down. Do that. Then what we have is the top portion of it here. This is the ilium, and that's all of this bone. The anterior portion here, right there, that is the pubis, and then the posterior portion here, that is going to be the ischium. And so those 3 bones fuse together to form the overall hip bone. So how I usually ask that is like I'll put a piece of tape on here and I'll ask like identify the specific bone, not the general bone. The general bone would be the hip, or I might even say, because I figure at this point the hip's a freebie question anyway. I say like I'm not asking about the hip, I'm asking about the specific bone. So on each of these 3 bones, we're going to have some features that we have to know. Get the list up again so I hit everything. So the ilium is going to have the most stuff on it. So go back again, my right hand here, this is the superior aspect of it. So if we take a look at this along the superior aspect of the hip, you're going to have this big long crest, and that's going to be the iliac crest. And on the anterior portion of it, it has a small point. This is like kind of gnarly. It's pretty older person skeleton. There's some weird bone growth, but like we would have, actually, I've gotten myself twisted around. There we go. So now we're looking at the internal view of the hip. So like we're in the pelvic cavity, looking laterally. This is the iliac fossa. And then this point right here is the anterior iliac spine, and then this is the inferior iliac spine. This is the iliac crest, and then posteriorly we have the posterior superior iliac spine, posterior inferior iliac spine. So anterior superior iliac spine, anterior inferior iliac spine. What else? So then for the rest of the ilium, we're going to have this large indentation right here. This is called the greater sciatic notch. And then it goes towards the ischium. And so the other structures over here are ischial structures. Yeah. And then the only other piece I think that we have on our ilium that we have to know is the auricular surface, which is this rough surface right here. So if we then go down inferiorly, again, we're on the inside of the pelvic cavity looking at what the internally facing side or medial side of the hip bone would look like. Then we get to this point right here. And that point is the the ischial spine, and then just below it is another little notch like we had up here. This is the greater sciatic notch. This then is the lesser sciatic notch. And then on the bottom inferior aspect of that lesser sciatic notch, you are going to have the ischial tuberosity. And the ischial tuberosity is basically what you're sitting on right now. It's kind of like what we think of as like the butt bone, you know, what really is like carrying your weight as you're sitting in the chair. And that rough patch gives it a lot of like muscle attachments. There's a lot of grip they can get, which we need because we have to move with just our lower legs. So then we have the ischium, all of this bone, and then we'll go into the pubis, which is more anterior. And so if we were looking kind of down through someone's torso, this is the pubis. The pubic symphysis would be right here. It'd be a fibrocartilage pad, and then you'd have your other hip on the other side. This allows for some flexibility and give between the two hips so that when you get an impact on the right side, it has a little cushion right here, so it's almost like a shock absorber. You have the obturator foramen, this big opening right here. And that obturator foramen is made up of the ischial and pubic bones. So it's not really a single bones feature. It's more of like a joined feature, like the acetabulum isn't a single bones feature. The pubic bone also has a pubic tubercle. A lot of times I don't quiz on this because I usually use the fake bones for it, and most of ours don't have a good pubic tubercle. If I find one, it's fair game, but I just haven't on a lot of them. What else do we need to talk about? So, oh yes.
Would you recommend us taking a picture of that bone?
Honestly, I tend to use the model bones more for the quizzes because that's what you mostly have available to study. These are mostly for instructor use, but they do show some of the features better, so I like to use them. So the pubic bone is basically like branches on either side. So you have the superior ramus of the pubic and the inferior ramus of the pubic bone. I don't think we have anything else on our list. There is an easy way to tell left and right. If you hold this bone with your thumb in the greater sciatic notch, then the iliac fossa would touch your ear and you'd talk as a mouthpiece into the pubic symphysis. So if it fits in your hand like a phone would, or an old-timey phone, right? Like back on the old corded days, then that's the same side of the body that it sits on, and that's about the same position it sits in the body too. So this is a right one because it fits in my right hand real easily, and I could like hold it up and talk in it like a phone. So then we have the femur, and now the proximal. I'll try and keep the proximal distal working for this one. So with the femur, get a little more height on here. So with the femur, this is one of the easiest bones to identify and to tell left and right. Most people know this just off site, even without ever taking a course. It's just kind of a real common bone. So it looks a bit like a walking cane, almost like you'd hold it on this end and then support your weight on that end. And that is kind of how your body uses it. So this head of the femur fits into the acetabulum. You can see the narrow neck region on here. I can tell, so superior, inferior is really easy on these ones because the head is so distinct, and then the distal end is going to be pretty distinct in and of itself, kind of like two big knuckles hanging down there. Anterior and posterior is also really distinct on the femur as well. The anterior surface is really smooth, whereas the posterior surface, while it's still smooth, it has a line that runs down it, and that's called the linea aspera. You can feel this really easily with your hand. So most people can tell left and right on the femur blindfolded. You find the side that has the handle. The handle faces towards you, faces medially, and then you find the side that has this ridge on the back of it. That's the posterior side of it. So now I know this is a right femur. You can also find a rough patch up here, the gluteal tuberosity, kind of like the ischial tuberosity. It's just a site of muscle attachment that gives you a lot of surface area. And then as we go down, like in the humerus, as we reach the distal end of this, it starts to flare out. And those flared regions, again, if you move your fingers down, they kind of get stopped right there. Those flared regions are the epicondyles. And it's this massive bone that supports the condylar or articular surfaces that we have on there. So we have two big condyles. We have a medial condyle, which is on the same side as the head of the femur, and a lateral condyle, which is on the opposite side of the head of the femur. The only other things we have are on the proximal end of the femur. We have these two massive bumps. These are the same idea as the humerus with the greater and lesser tubercle. However, because they're so big and distinctive, they get their own name, and so we call them the lesser and greater trochanters. All right. So then, moving down, still keeping our proximal and distal, you have the tibia. Now, this is a right femur, and I grabbed a right tibia. This is not the matching bone. This is a much smaller person's tibia, but you can kind of see how they would fit. And now there should be some pads in there. So there are meniscus pads, and we can see these on our knee joint. This is as good a time as any to do the knee joint. So that's how this would sit, with these two kind of knuckles, these condyles of the femur, being supported by these two fibrocartilage pads that are the lateral and medial meniscus. So if we kind of look in there, you can see that they are cupped, and they're going to help keep that femur centered on the top of the tibia, which helps for support purposes, because if you'll notice, if we look at the bones, there's very little bony structure there that actually keeps this joint aligned, unlike, you know, the ulna and the humerus, where you have like a very distinctive hinge joint. So our meniscus help keep that in there, as well as two ligaments that are within the joint, and then two ligaments that are on either side of the joint, and then our big anterior ligament. So within the joint itself, we have our cruciate ligaments, the anterior and posterior cruciate ligaments. These are the ones that you always hear about, the ACL and PCLs, like kind of every field athlete's worst nightmare for a tear. These ones essentially help mostly with preventing the tibia from sliding too far forward or sliding too far back, and then femur runs off of that support structure. So when they tear, it's usually because of a blow that has led to this kind of a tearing motion. The one that you see from the front is shockingly the anterior cruciate ligament. The one that you can see from the back, also shockingly, the posterior cruciate ligament. Just be careful, because you want to abbreviate these, because that's how we normally see them. Most people that hear about an ACL or PCL tear can't tell you what the full name is. So just like that on the quizzes, I want you to write the whole thing out, not just abbreviate it. The other ligaments that we have on this are going to be the medial and lateral collateral ligaments. You can also call them the tibial and fibular collateral ligaments, whatever sticks easier in your head. These ones are just, as the name implies, running from the bones of the lower leg, whichever they're on, the fibula or tibia, up to the femur, and help stabilizing it on those lateral and medial aspects. Then the last one that we have is what covers the anterior portion of this. And so running from the tibial tuberosity, this rough patch right here, on up to the patella is the patellar ligament. And then running from the patella on up to the quadriceps muscles is the patellar tendon. Remember, tendons go muscle to bone, ligaments go bone to bone. So that's why we have two things here. And part of this is to protect the knee, but another thing that this does is the patella creates a pivot point, increasing the leverage that can be applied to the lower leg. So there is a surgery called a patellectomy, where they remove the patella, and it increased the caloric cost of walking by about 20%. So the patella really does help make your job of moving or ambulating on two legs a lot easier than if it was just a simple tendon that ran from muscle to the tibia itself. It also provides kind of like a wear point, so that soft tissue is not grinding against the edge of a bone too. All right, so back to the tibia. Now without the cartilage, we can see that there are, I'm going to kind of break my proximal distal rule for a second. We can see that there are these condyles here. And with those, we do have this intercondylar, which means inter is between. So intercondylar eminence, this extension that goes up. Again, that kind of helps center the femur on this bone and this joint so it doesn't slip off too far. On the anterior surface of the tibia, I can find that because I look, it's kind of like a triangle, and the point is going to face anteriorly, this long ridge. It's called the anterior crest or the anterior margin. And you can feel this. This is your shin. Is what you kind of kick when you clock a stool wandering around at night. And then on the proximal portion up here, this is going to be a rough patch. And it's really small in this because this is a tiny tibia, but this is normally pretty distinctive. You can feel it on your own leg, and that's going to give all that site of attachment for that patellar ligament so it doesn't just rip off the tibia by accident. Then as we go down inferiorly or distally, we're going to get to the end of the tibia, and we don't really have anything on here except for this big lump. And if you remember the radius and the ulna, they both had points on their distal ends that were the styloid processes. This basically is the same thing. And so I have another tibia. This one is articulated, and this is a left tibia. Notice that this is now on the opposite side of the one we were just looking at. But this is the only one I have that's articulated. And so we can see our first tarsal bone, the talus right here. The fibula is lateral, and then the tibia is medial. And one way to remember the tibia is medial is that big point we were just looking at, it's called the medial malleolus. So I'm always shocked by how many people get this one wrong, and they'll call it like variations on that. If you just remember the tibia has a medial malleolus, that it's like a styloid process in the arm, so it forms a bracket around the ankle. This is actually what you feel when you think of your ankle bones, that big nub down there. It's that medial malleolus. And then the fibula, lateral malleolus, is what you feel on the outside of your foot. But the tibia is medial, fibula is lateral. Fibula has the lateral malleolus, tibia has the medial malleolus. This also has a nice big tibial tuberosity here. This is probably a more appropriate size tibia for the femur that we were looking at. The fibula, it's going to be the longest bone in the body. Well, I shouldn't say that. It's the longest and skinniest, I guess. The femur is longer, but it's really beefy. So this is also a very distinctive bone because of how long it is, but how thin it is. This isn't really a weight-bearing bone. This is more of a site of muscle attachment. It's kind of loosely connected underneath the tibia here, and then the lateral malleolus here is bound to the tibia too. We don't have it on our list, but there is a notch in the tibia that allows for that bone to kind of articulate there. Like our radius had an ulnar notch on the distal end. And those two malleoli form a bracket around the talus, which is the first bone of our tarsals and one that we do need to know. We don't need to know anything on the fibula except for the head and the lateral malleolus. The lateral malleolus, to me, it's like someone had an arrow that they cut in half. And so it's like half an arrow, whereas the head is much more blocky on this end. Then we have our foot. And so the talus is what we were just looking at when we were looking at the tibia that was articulated. This is where the weight of your body sits on the foot. This is actually a kind of a cool one. It's articulated with springs, so you can kind of see how if I press down on it, it sort of springs to that surface and it'll pop up. Your ligaments should operate in that same way too. The ligaments binding your tarsals and the arches of your feet together act as a biologic spring. This is very apparent in kangaroos when they use that saltatory locomotion when they're hopping along. It's like dribbling a basketball. It saves you energy because you're relying on that elasticity built into the system. Our running gait utilizes that as well too. There's interesting stuff on like barefoot runners and springiness of arches and things like that. Well worth the read if you're curious about it. So for our bones, we only need to know the talus and the calcaneus by name. So that's the heel bone, and I'll always have them articulated like this. They're really not that hard to tell on their own because they're very distinctive, but I use a complete articulated foot on the quizzes and practical. For the other tarsals, that's just knowing that they're tarsals. So even though they're on the term list, you can just focus on talus, calcaneus, and then tarsals. Same idea for the foot as the hand. Imagine a foot with toes that were 4.5 to 5 inches long. A little creepy. So when you're looking at these, remember the sole of your foot is mostly or half and half tarsals and metatarsals. Your phalanges, your toes themselves, the little piggies, they don't start until out here. And you have on the big toe a proximal distal and then on the rest of them, proximal, middle, distal phalange for those. That's it.